In this lecture, we are going to talk about the chronic fetal hypoxia. Chronic hypoxia happens due to reduction in the placental blood flow over a long period of time and is associated with underlying conditions such as preeclampsia, fetal growth restriction. When you look to this picture, you can see this is a normal fetus. He requires a large amount of dropping in the oxygen to elicit his response. Whereas a fetus who is already deprived, the lower the basal PO2, the smaller the fall in the PO2 to elicit the response. So this fetus will require, the one with already deprived, require a small drop in the oxygen concentration and he will elicit the response. So there is a direct relationship between the intensity and the duration of uterine contraction and onset and magnitude of the late deceleration of the fetal heart rate. How we could interpret the CTG in a patient with a chronic hypoxemia. Direct changes in the fetus. There is direct changes in the fetus and there is indirect change. The direct changing like fetal breathing movement will be ceased and this can be reflected on minor decrease in the short and long-term variability. While the hypoxia getting worse, what happened? The loss of fetal flexure tone. So when there is loss of fetal flexure tone, you know that the fetus long-term variability delay in the movement disappear, and will be reflected on the long-term variability completely absent and marked reduction in the short-term variability. We know from the previous lecture that the variability is coming from different sources. One of the sources is blinking, breathing, and fetal movement. Now we talk about the direct changes, and we will talk now about the indirect changes for the fetus. When there is increased hypoxia, the fetus will redistribution of the cardiac output such that the vital organ receiving the main blood supply where it's depriving the other organs from the blood supply. What will happen? There will be reduced the blood supply to the kidney, and this will leading to reducing and cease of the urine production. And then will be severe oligohydramnios, which can be presented or can be reflected as variable deceleration or late deceleration, may or may not have bradycardia. The other thing that the increase in the hypoxia will stimulating the contraction of the intestinal muscles and relax the anal sphincter tone, and this will lead to the meconium passage. Hypoxic insults that are slow in onset and persistent over time, allowing the fetus to make hemostatic adaptations, including metabolic adjustment, and elicited different fetal heart rate pattern. Let us look to the journey of a chronic hypoxia, and asphyxia, how it is occur. At the beginning, there will be retroplacental reserve diminished, but this is diminished will not affecting the fetus. Since it is giving enough oxygenation, you will have normal baseline fetal heart rate, normal long-term and short-term variability. What happens if this reserve getting diminished more than what we will get late deceleration with a small amplitude, less than 10 beats per minute, but we will have normal long and short-term variability. So the presence of shallow deceleration with good variability, it's indicated that this is the first stages. It is not yet severe. If the fetus acidosis getting more then what you will get reflex late deceleration 20 to 40 beat per minute with decreased latent period, shorter in the delay time between the ASIM of the contraction and the beginning of the late deceleration. At this stage, fetus not requiring active resuscitation measure. Where if the fetus developed hypoxemia, mild to moderate mixed metabolic respiratory acidosis, can be presented by reflex late deceleration, getter deeper, but more than 40 but less than 80 beat per minute, and rise the baseline. In this stage, the fetus depressed but require active resuscitation, and measuring increase the risk of central nervous system damage. Now, if the fetus hypoxemia becomes severe metabolic acidosis, it will be presented by small, direct, fixed tachycardia, diminished late deceleration amplitude, absent of long-term variability, pencil-like effect. And at this stage, the fetus severely depressed and require maximum resuscitation and increasing the risk of long-term central nervous system damage. You can appreciate that there is difference between the first shallow deceleration and the second shallow deceleration. At the beginning, the variability is intact, but here the variability is absent. Then the deceleration will disappear. This is not a good sign. The deceleration disappear. If there is a good variability, then it is good. But if the deceleration disappear with a flat CTG, this is indicated progressive irreversible bradycardia and intermittent arrhythmia. And if the baby here is severely metabolic acidosis, a fetus requires severely depressed but require maximum resuscitation measure may or may not succeed and increase the risk of long-term fetal asphyxia disease. At the end, the fetus fed up and he might have cardiac arrest.